So Vadastuximab talirine is an antibody drug conjugate. The antibody targets a protein on the surface of myeloid leukemic cells or myeloid blasts, CD33. The antibody is bound with a stable linker to a highly cytotoxic agent called PBD. And when the drug is infused, it travels to the tumor. The antibody binds the cell surface, receptor CD33. The antibody drug conjugate, ADC, gets internalized into the cell, into the leukemic cell, where gets endocytosed. And over the process of cellular trafficking and hydrolysis, the drug actually ends up getting released inside the cell, attaches itself to DNA, interferes with DNA repair, leads to DNA damage, and then cell death. So it's a targeted cytotoxic approach. The preclinical studies were quite promising, led to a phase 1 study of Vadastuximab talirine in patients with relapsed refractory AML, and also some patients in the upfront setting who did not have other possible options for therapy. The monotherapy was quite promising. There was a remission rate that ranged in the 20 to 40%, depending on the dose. It was a dose escalation study. It was in that range, and in general, it was well tolerated, which was the predominant goal of that study. Smaller cohorts within that study investigated combinations of Vadastuximab talirine and also use of Vadastuximab talirine in various patient populations. The abstract that we are talking about today is the combination of Vadastuximab talirine plus hypomethylating agents. Now, hypomethylating agents are increasingly used as treatment in AML for patients who are unfit for traditional aggressive cytotoxic chemotherapy, mainly because they're well tolerated. They don't lead to significant amount of hypoplasia or aplasia or decreased blood counts. They can be given on the outpatient side, and they seem to be fairly, as far as tolerability goes, optimal for older patients who may not tolerate the more aggressive approaches. The challenge with hypomethylating therapy is one that they oftentimes take time to work. You may need 2 or 3 cycles of treatment before you see response. And actually, remissions are relatively low. In the majority of studies with Decitabine or Azacitidine, which are the 2 hypomethylating agents that are out there, the rates of remission range from the mid-teens to the high 20% range as single agent treatment. Of course, those individuals who achieve remission do well, which is great. And some people, although they may not achieve remission, maybe have stabilization of disease, maybe have improvements in blood counts, and that too is a benefit to older patients with AML. And there is some translation to improved survival. However, in recent years, there has been an increasing trend to combine these more gentle treatments with other agents that are more targeted, that perhaps can enhance the rate of remission and the rate of response. And one of these is Vadastuximab talirine. So the cohort in this phase 1 study that looked at the combination of hypomethylating agents, azacitidine or decitabine, plus a lower dose of Vadastuximab talirine to see if we could enhance the cytotoxic activity for treatment of these patients and lead to a higher rate of remission.